Okay, assalamu alaikum everyone. My name is Layan. I'm a fourth year medical student, and today, inshallah, we'll be covering the ECG crash course. Now, from how much content this covers, I didn't have time to make the slides pretty, but here's a smiley face. This lecture will cover around 5 or 6 of your clinical lectures. So we're gonna go through ECG basics, the tachyarrhythmias, bradyarrhythmias, ECG in ischemic heart disease, and atrial enlargement and hypertrophy, ventricular hypertrophy. So that's around like 5 or 6 lectures. So before we start, I'm a very firm believer of understanding makes memorizing so much easier. So I'll be explaining the concepts in detail, but only giving you the things you need to know, because the clinical lectures in third year, like 80% of them is just a lot of like not useless, but like too much for your level. So inshallah, I'll be able to narrow it down to what you need to know. So feel free to interact, unmute, or send in the chat box whatever you have questions, or you want to interrupt, you want to take a break, you want to ask anything, please feel free to do so. So first thing, basics, the conduction system of the heart. So let's start. So the SA node over here is the pacemaker of the heart, which means it's automatic. It doesn't need an impulse to be sent to it in order to start the heart. It's just from Allah, it just starts the heart on its own. It's automatic, okay? So this is the pacemaker of the heart, meaning that it sets the rhythm of the heart, okay? So if there are any abnormalities in the SA node, you'll have abnormalities in the rhythm of the heart. After the SA node sends the impulse, it's going to go to the AV node. Now, there is a delay in the conduction from the SA node to the AV node, and the reason for this is that we do not want the ventricles to contract right after the atria contracts. We want the ventricles to have time to fill in properly with the blood, and then for them to contract and pump the blood to the rest of the body. So there is a slight delay from the conduction from the SA node to the AV node, okay? Now, after the AV node, it's gonna go to the bundle of His, and then to the right and left bundle branches, okay, and then to the Purkinje fibers to supply the myocardium. This is in general the basic conduction system of the heart. Now, this conduction system can be translated onto a paper through the ECG or electrocardiogram. This is the basic picture that you get. Now, it's really important to understand what each part of this wave of these waves mean, because any abnormalities in any part of them can easily tell you what's happening in the heart if you understand what each one means. So starting with the P wave, this is the P wave. Now, the P wave represents atrial contraction, okay? That's all you need to know. Atrial depolarization or contraction, same thing. So this P wave starts here, ends here, means that the atria contracted. So if you get an ECG where there is no P wave, you know that the atrias are not contracting, so there's something wrong in the atria. The PR segment, which is this part over here, it's the delay that we talked about. It's the delay of conduction between the SA node and the AV node. So there's a delay here, just giving enough time for the ventricles to fill blood before they contract, okay? That's why we call the AV node the gatekeeper. Now, for the QRS, which is this part here, this one is the Q wave. This long part here is the R wave, and this dip is the S wave. Okay, so altogether, this is the QRS complex. The QRS complex, before that, okay, let's do this here. The QRS complex, it just represents the ventricular contraction, okay? So the P wave is the atrial contraction, and the QRS is the ventricular contraction or depolarization, okay? Now, the PR interval is basically from the start of the P wave to the start of the QR, which is over here, this part. Now, the PR interval is important because it basically just tells you how long is is it taking for the electricity to go from the atria to the AV node in total? So this over here, we need to know it because it's used in determining or differentiating pathologies. Did something happen?
Yes, the screen is not shared anymore.
Okay, 1 second, let me try then. Is it working?
Yes.
Okay, thank you. Okay, sorry about that. Now, we talked about the P wave, we talked about the PR segment, the PR interval, and the QRS complex. After that, we have the J point. The J point is nothing visible in normal ECGs, but you need to just keep this point in mind because we use it in STEMIs or myocardial infarctions. It really helps us in the pathologies. Just keep this in mind. Now, the ST segment, it just represents ventricular depolarization, the end of ventricular depolarization, beginning of ventricular repolarization. So like we said, this part over here means the ventricles contracted. This part over here that means that the ventricles completely went back to rest or repolarized. That's it. Now, the T wave is, sorry, wait. This part represents the beginning of the ventricular repolarization, sorry. The T wave, it means that the ventricles are relaxing now, okay? So this is ventricular relaxation. This is ventricular contraction. This is the time between them, okay? That's it. All this together, the QT interval, it's just, in total, it's just everything related to the ventricles from the time they start contracting to the time they fully relax. So contraction, relaxation, time in between, okay? Now, the U wave, this is just something like you see when the patient has hypokalemia. So just keep this in mind, it's pathological. It's not supposed to appear normally. And even if the patient has hypokalemia, it's not always there. But when it's there, it can tell you that the patient has hypokalemia. It's just a sign. Now, I want to go into why do we see these deflections on the ECG? Okay, now to start this concept, you have here a voltmeter or a meter that just is measuring the difference in charges, okay? You have a positive end and you have a negative end, okay? Now, this over here only deflects or moves if there's a difference between the charges here and here, okay? So here it's in positive and here it's positive. So it's not gonna be moving. It's still, okay? It's not gonna move because the difference in charges between here, this area and this area, it's the same, positive, positive. It's only going to deflect if there's a difference between the charges on this side and on this side, okay? So let's take this, for example. These are, right here, these are normal cells in the body, just any cells, okay? We know that cells normally inside they're negative, right? We have more negative ions inside than outside, so they're going to be negative, and the fluid outside or around the cells is mainly positive, right? Now, if you remember from year one, what does depolarization mean? Like when a muscle comes to contract or the cells of a muscle want to send a nerve impulse, they become depolarized, right? Depolarization just means that there's a rush of positive ions inside the cells, okay? Now, when the positive ions rush inside the cells, the outside becomes negative now. So, do you see the difference? We had positive cell ions here. They rushed inside the cell. So now this part is negative and the inside of the cell is positive. So now there's a difference in charge between this area and this area. So the arrow is going to deflect, okay? This is translated on the ECG paper as an upward deflection, okay? So in other words, it means that the depolarization is happening in the direction of the positive electrode. This over here is connected to the positive. So this is our positive electrode. the wave of depolarization is going this way. You have positive ions entering in this direction. So the cells are becoming depolarized in this direction. So this cell becomes depolarized first, then this cell, then this cell, then this cell. So the direction of depolarization is this way, okay? And the positive electrode is over here. So it's going in the same direction of the positive electrode. So it's gonna translate on the ECG paper as an upward deflection, okay? Now, all the positive ions, خلاص, they went inside, all of them. So again, we go back to the phase where the charge here is the same as the charge here. So the meter is gonna go back. Sorry?
You are lagging. Can you repeat again?
Yes, sure. Which part did I log on?
After you said the positive ions enter the cells.
So here?
Yes.
Okay. So the positive ions start entering the cells. Why? Because that's how depolarization happens, right? So when the positive ions enter the cells, we're gonna have negative outside, okay? Because the positive ions are rushing inside. Is my voice clear now?
Yes.
Okay. So because now we have negative outside, there's a difference between the charges on this side and on this side. So the arrow is gonna move, okay? So let me just clear the pen. So again, the positive ions, they went into the cell, creating a negative potential outside, okay? So now here you have negative potential, here you have positive potential, and the cell depolarization is starting here. The depolarization is going in this direction. And this cell is becoming depolarized, then this cell, then this cell, then this cell, because the positive ions are slowly entering the cells. So the depolarization is going in this direction, okay? This is in the same direction of the positive electrode. And we said this is the positive, so this here is the positive electrode. When the depolarization moves in the same direction of the positive electrode, you get an upward deflection on the ECG, like we see here. Is this concept clear?
Yes. Thank you.
Okay. Now, why does it go back down? Because after all the positive ions entered, خلاص, all of them entered, the depolarization is complete, you'll have negative potential here and negative potential here. So we go back to the phase where the potential here is the same as the potential here. So the arrow will move back to neutral. So the wave will go back down, okay? So it moves up, there's a difference between here and here. And then it moves back down because خلاص, the polarization is complete. We go back to same charges here and here. So this is in general how readings on ECGs are created. Now, this is basically what the doctor is saying. We have positive deflection, which means this is the isoelectronic line. Positive deflection, yani above the line, all of these, and we have negative deflection. So all of these deflections mean that we have the depolarization moving towards the positive electrode. This means it's away from the positive electrode. This is basically what he's saying. You have a meter connected. This is the positive end, negative end. When the wave of depolarization is in the same direction of the positive electrode, you get a positive deflection on the ECG. Okay, same thing here. Do you see how the wave of depolarization is going in this direction, away from the positive electrode? You'll get a negative reading on the ECG. Okay, now this is basically what he's saying. Is this concept clear?
Yes.
Okay, so this is in the case that your electrode is connected exactly parallel to or 90 degrees to your wave of depolarization. So it's very easy. You'll just get, okay, upward means towards, down means away. But the heart is a 3D diagram, right? We have many different directions of signals, of impulses, of electricity. So how can we capture all of this? basically, imagine that this is a cross-section of the heart cells, okay? We have impulses traveling in this direction. They can easily be read by this. This basically is the lead that we talk about, like the leads for the ECG, okay? We have this lead that can read the impulses moving this way. Now, what if we have an impulse also going this way, or a wave of depolarization going this way? Will this blue lead be able to detect it? It's very hard because it's not really aligned with it. So what we do is we connect a second lead that's more in line with this one, okay? So this second lead will be able to read these directions, and the blue lead, the first blue lead, which is this one, will be able to read impulses going in these two directions, okay? And the red one up and down. But again, the heart has so many directions of impulses going. So we just keep connecting more leads and more leads and more leads and more leads. So each lead, like the green lead, will be able to read directions going this way. The blue lead will be able to read this way. The red lead will be able to read this way, okay? Together, they'll give you an accurate reading of impulses traveling in these directions, okay? But this, again, is a 2D picture. The heart is 3D. It's like a sphere, not a circle, okay? It's 3D. So we have impulses moving in the frontal plane, which means 2D, okay? These are the directions. But you also have impulses in the transverse plane, as if they're coming outside towards you or inside towards the paper. So you have impulses going in the frontal plane and you have impulses going in the transverse plane, okay? That's why we have so many limb leads or leads in general to read the different impulses going around the heart. Is this idea clear?
Yes.
Okay. So the purpose of the leads in general is to view the heart's electrical activity from different angles, okay? So the first type of leads is called the bipolar limb leads. Now they're called limb leads because they're placed on the limbs. And the function of these leads is to read the electrical activity from the frontal view, okay? So this is really important, you have to know this. So what we do is, imagine that these leads are basically the meter that we were drawing, these, okay? These are leads basically, okay? So we have lead 1, lead 2, and lead 3. Lead 1 has a positive electrode and negative electrode, of course. The positive electrode is placed on the left arm, the negative electrode is placed on the right arm. So this is lead 1, okay? The positive is placed on the left arm. So this is the positive side, this is the negative side on the right arm, okay? For lead 2, which is this one, the positive is placed on the left leg. So this is the positive end, this is the negative end. And for lead 3, the positive is also on the left leg. So this is the positive end, this is the negative end, okay? So how I remember this is that positive is always on the left side, okay? And negative is on the right arm and left arm, okay? So positive is PLL. I just write PLL, L, and then NRRL, okay? I don't know if this helps you guys or not. You can make mnemonics how you can remember them. But just remember the positive electrode is always on the left side, okay? And then if you draw this triangle, you will easily remember it in the exam. Just draw it this way. So you have right arm, left leg, okay? And that's it, there's no right leg. So if you just remember this is lead 1, this is lead 2, this is lead 3, okay? So these will read the impulses from the heart going in the frontal plane, okay? Now, the second type of leads is the unipolar limb leads. Now, these also read the electrical activity from the frontal view. It's AVR, AVF, and AVL. The difference between these leads and the lead 1, 2, and 3 is that these leads are unipolar, which means they don't have a positive electrode and a negative electrode on two sides. They have a common like part here that's Khalaf negative, and they use that in reference to the positive end. Now, don't confuse yourself. You don't need to fully like really understand this deeply. Just really know how they're placed. So again, in the exam, just draw right arm, left foot or left leg. Draw the triangle, 1, 2, and 3. Okay, so this way you'll remember, and we remembered that the positive is always on the left. So positive is always on the left. So in the left arm, when we have positive, on the left leg we have positive, and that's it. The rest are negative. So this way you can remember the directions. Sorry. So for lead 3, this is positive and this is negative. This is negative. You just fill in the gaps. This way you'll never forget them, inshallah. And for AVR, AVL, and AVF, they're placed in this direction, okay? They're not really placed exactly on the heart. It's just to show you that there's a common point here that they use as reference, okay? Now, this is really important. Again, please know how to place these really well, okay? Remember, right arm, left leg, draw the triangle, 1, 2, 3, and then positive is always on the left, okay? Now, do you understand how the limb leads work?
Yes.
Are you sure?
Yes.
Okay. So these leads are exactly what we discussed in the beginning. They're just basically like they sense the electricity going in which direction, and we have positive end and the negative end. And if the depolarization of the heart is going towards the positive, it will deflect up on the ECG, like here. And if the depolarization is going in the opposite direction, it will go down, it will deflect negatively. It's the exact same concept of what we explained with the cells in the beginning. And you need to remember where they're placed, like lead 1, lead 2, and lead 3, where they're placed. Right arm, left foot, triangle, everything, okay? So this is basically, okay, what the limb leads are. Now, the third type of chest leads, of leads in general, are chest leads. They're called chest leads because they're placed on the chest. Now, these leads will read electrical activity from the transverse view, okay? So this is the difference. The first leads, V1, 1, 2, and 3, AVF, AVL, AVR, they read everything in the frontal plane, as if it's 2D. It's a piece of paper, it's just up, down, diagonal, okay? These chest leads are really helpful and important because they can read electrical impulses in the transverse point of view. So if we take a cross-section of the chest and we look at it from up, this is basically the depolarization waves or impulses that these leads can pick up, okay? Or the transverse view in general. So you need to remember where they're placed for your OSCEs, and sometimes it comes, maybe like one question. You need to remember where they're placed. It's just memorization. This is how you can remember them. This is where they're placed. V1, V2, they're like placed around the chest, okay? So this is how they're placed. I'm not gonna go through this. You just have to memorize it, okay? So all together, combining all the leads together, lead 1, lead 2, lead 3, AVF, AVL, AVR, V1, V2, V3, V4, V5, V6. This basically, think of it as we're able to now detect impulses in every single direction going in the heart, whether it's up, down, in, out, everything. We can really get an accurate image of the electrical activity of the heart. That's why we use all these leads, okay? And each lead will tell you something different, okay? And we'll get to that later, inshallah. So think of it as basically you're looking at the heart from different cameras. It's all the same heart in the end. It's just gonna look different from each angle. Like it's as if you're taking a picture of someone from multiple different angles. In each picture, it's the same human. It's just, it's gonna look very different because the angles are different. That's why in the ECG, all the different leads, it looks like complete different heartbeats and rhythms, because they're actually just the same thing, just different angles, okay? Now, these precordial chest leads, I want you to be familiar with how the normal looks like, okay? So that you're able to like tell how the abnormal looks like, you know? So just be familiar with how it is. If you want to keep like a screenshot, so when you're solving, you're able to compare and stuff like that. Just be familiar with how the normal looks like. And if you can see, they don't really look like your typical wave. You know what I mean? Like the one in lead 1 and lead 2 and stuff like that. But just keep in mind. So that's it. Yeah, so what do we need to know from all of this? You really need to know the leads placement and what each phase of the PQRST corresponds to. Are there any questions?
No, thank you.
Okay, so I want to explain something that's very interesting and it's really nice to understand. Okay, so if you're looking at the ECG, it's really easy to understand. Let's take lead 2 as the, or lead 1 as, or lead 2. Let's take lead 2. Lead 2 is going in this direction, okay? With negative and positive. If you take this as reference, it's very easy to understand why atrial depolarization is up, because you have the heart in this direction, okay? The atria is going to depolarize this way, okay? And lead 2 is this way, صح? The direction, negative, positive. That's why they're both in the same direction of depolarization, so it's going to go up, okay? But did you ever wonder why the QRS or the ventricles depolarization goes down, then up, then down again, then up? It looks really different in the atria, you know? The reason for this is this first notch, okay, of the QRS, which is the Q, is because when the ventricles depolarize, the first thing that depolarizes is the septum, and it depolarizes from left to right. Okay, keep in mind, this is right, this is left. It's as if the patient is looking towards you, okay? So it depolarizes from left to right, so in this direction. Lead 2 is in this direction. So you have the wave of depolarization going away from lead 2, okay? That's why it kind of dips down, there's a negative, okay? Then what happens is, after the septum is depolarized, here, this is the second one, okay? After the septa depolarize, it's the wave of depolarization is going to continue down like this. That's in the same direction as lead 2. So you're going to get upward deflection. I think I should use black. Yeah. So it's going to start depolarizing down. So you get an upward deflection because that's in the same direction as lead 2. Then here, it's going to, after this part depolarizes, you still have the lateral sides of the ventricles. How does that spread? It spreads upward. These start to depolarize. That's in the opposite direction of lead 2. Remember, lead 2 is like this. This is negative, this is positive. So when they start to depolarize upwards, it's in the opposite direction of lead 2. So the wave is going to go back up, back down. Okay? Now, why does it then come back to the surface? Because the ventricles are completely depolarized now. So do you understand why it looks like this on the ECG?
Oh, yes, yes. Thank you.
Okay. Okay. Now, do you think after knowing all of this information, do you think you can locate which part of the heart is injured just by looking at the ECG? Even if you don't know, just like take a guess. Okay, I can tell you that yes, you can, and this is very, very important. You need to memorize this like back of your hand, like really, really, really important, okay? Very important. So basically, all the different leads are attached and they can read from all different sides of the heart. Now, certain leads can give you a reading on what's happening on the lateral wall of the heart, like AVL, and lead 1. Why? Because they're basically placed on, like the AVL is reading directions going this way or impulses going this way, and lead 1 is also reading impulses going this way. So AVL and lead 1, they can read or tell you if there's anything wrong or if is everything okay with the lateral wall of the heart, okay? So when we get to the part of the lecture where it's about ischemic heart disease or, ischemic heart disease, when you see abnormality in AVL and lead 1, you immediately know that the artery that that the problem is happening in is the left circumflex. Why? Because AVL and lead 1, they give you a really clear image on the lateral wall of the heart. So pretend as if AVL and lead 1 are this camera. So this camera gives you this view, a lateral view, really clearly. You know, even if this camera can also kind of give you a lateral view, this camera kind of can, this camera kind of can, but this camera in specifically gives you such a clear side of the lateral view. That's why you really depend on these two leads to know to read the lateral wall of the heart. Okay. Now for leads 2, 3, and AVF over here, these give you the inferior wall of the heart, which is supplied by the right coronary artery. Like we said, many can show you what's happening in the inferior side, but this camera in specific, or lead 2 and 3 and AVF, they give you a really clear image of the inferior side. That's why we depend on these 3 leads to look at the inferior wall of the heart, okay? So let's say you have a STEMI in lead 2 and 3. We'll get to what a STEMI is later. But if you have a STEMI on lead 2 and 3, you know that the inferior wall is the one that's being infarcted. So that means that the right coronary artery is the one that has the occlusion, okay? So that's how you can kind of see which part of the heart's affected just by looking at the ECG. Same thing here, V1 and V2 will give you the reading on the septum. And yeah, this is basically it. This is what you have to memorize really well, is which leads give you which side or surface of the heart. You really need to remember this really, really well. Now, okay, we talked about these. These are all the leads in total. Now, before we start, do you understand the basics of ECGs?
Yes, thank you.
Okay. Now, we looked at this. Now, what I need you to remember from this is that a small square on the ECG is 0.1 millivolts or 1 millimeter or 0.04 seconds. Okay, that's one small square. You need to remember this because in different slides and many slides, they'll tell you, oh, it has to be more than 2 millimeters. Then in another slide, you'll see it has to be 0.10 millivolts. Another slide, you'll see it has to be 0.12 seconds. You know, they're all talking about the same thing, but just know that one small square is 0.1 millivolts or 1 millimeter or 0.04 seconds. Okay, so just have these in mind so you can understand what the doctor is trying to tell you. Now, yeah, okay. You know, a flat line means there's no activity happening. Now, this is a typical ECG. What you need to know from this is the normal duration of each part of the ECG, because any changes in these will lead you towards a specific pathology, okay? So how I like to remember it is by the number of squares, because if you just remember the number of squares, you can just you can then figure out how many seconds or millivolts or millimeters it is by just going back to this and multiplying it, you know? So I like to remember that the PR interval is usually 3 to 5 small squares. The QRS interval or complex is usually 1.5 to 2.5 small squares. The QT interval, which is all of this basically, it's usually 9 to 11 small squares, okay? Yeah, so see here, they're using milli and stuff, same thing. Just remember the squares. It's way easier to remember the number of squares. so you can read the ECGs way better. Now, if you have any questions, please let me know and interrupt me. That's okay. So let's start. How do you read an ECG? First step, in every ECG, you calculate the rate, okay? Second step, you determine the rhythm. Is it regular or irregular? How do we do that? You look, is this space the same or is it changing? It looks the same, so it's a regular rhythm, okay? Third step, you look at the P waves. Are there P waves? Yes, we have P waves and they look normal, everything is okay. This means the atria are contracting. Step 4, you determine the PR interval. And step 5, you determine the QRS duration morphology. This is how you approach any ECG that you see, okay? There are exceptions here and there where you can just recognize the ECG just by looking at it. But in general, these are the steps you need to follow. Rate, rhythm, P waves, PR, QRS, okay? So let's start. Of course, determine the axis. We'll go back to this later. I'll explain what an axis is. First thing is the heart rate. How do you determine the heart rate? There are two ways. You either you take the number of big squares between each R, okay? So in this case, the number of squares between the two R's, this is Q, R, S. Okay, that's why I'm saying two R's. The number of big squares is 3, okay? So what you do is you just divide 300 by the number of big squares. Or you can divide 1,500 by the number of small squares. No one uses this because you can't really zoom in this much, like to count each and tiny square. So just have this formula in mind. 300 divided by the number of big squares. So let's look at the purple one. You have 1, 2, 3, 4 big squares. So it's 300 divided by 4, which is 75. Let's look at the green. You have 1, 2, 3, 4, 5. So it's 300 divided by 5. So the heart rate is 60, and so on. Now, can you guys calculate what the heart rate is here?
$60.
60? Yes, how did you find 60?
300 divided by 5 squares, which is 60.
Okay, where did you count 5 squares?
Were you talking about a specific part of the ECG? I thought the strip on the top.
On the top? No, you have in order to do that, you look at this one, the rhythm strip.
Oh, if it's this example, then it's 300 divided by 4 squares.
Yes, exactly. So you have 1, 2, 3, 4 squares and a tiny bit. So it's around 75 beats per minute. Okay. You can't look, you can like look here, for example, it's also 4. You can look here, it's also 4, but you can't look at this as a whole because this is lead 1, this is lead AVR, this is lead V1, this is lead V4. Okay. So if you want to look like at a full strip, you look at the bottom one. It's just a full strip of lead 1, okay? Now, is it a regular rhythm or irregular rhythm?
Regular.
It's regular, yes, because you have 4 squares between each one. It's not changing. So the first step is determine the heart rate and then the rhythm. Or you can look at the rhythm and then the heart rate, whatever you want. Now, okay. Now, let's say that you get an ECG and it's irregular. How do you find the heart rate? We can't use the formula, right? Because if it's irregular, it means there's a different number of squares between each one. So how do you know which one to use? So we don't use the 300 divided by the number of squares for irregular rhythms. We just count the number of R's. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. And then you multiply it by 6. okay? So you count the number of QRS complexes and you multiply it by 6. So here it's 9 times 6, wait, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Oh, it's 12 times 6, which is 72. And don't use this formula if it's a regular rhythm. Okay, I was just like demonstrating how to use it. So if it's a regular rhythm, you do 300 divided by the number of big squares. And if it's irregular, you do the number of QRS complexes times 6. Okay, so, and you use this strip always to calculate rate and rhythm, you use the bottom strip. So is everyone comfortable with finding the rate and the rhythm?
Yes.
Okay. Now, how do we determine the axis? What is a QRS axis in the first place? So the QRS axis is basically the overall direction of depolarization. Now, in general, you have the heart here. In general, overall, the depolarization wave is going to move this direction. صح? Because it goes from the atria to the ventricles. Yes, there are some differences here and there in the septum and stuff like that. But overall, the overall vector is that the direction is going this way. So this way means it's between 90 and minus 30. Anywhere here is normal. This is a normal axis. Like if the overall direction was this way, it's still considered normal. If the overall direction was this way, it's still considered normal. So an axis is just the overall direction of depolarization. So if you look closely here, the normal is between minus 30 and 90. Anything here is normal, okay? Because the heart can depolarize this way, or this way, or this way. You know, these are all still overall normal. Now, let's say the overall axis of the heart is this way. Is this normal? It's not normal. The heart isn't supposed to be depolarizing in this direction. So what do we call this? We call this a right axis deviation. Remember always when you have the heart, this is right and this is left, okay? So this is normal. If it moves this way, this is a right axis deviation, okay? Anything beyond 90 degrees or minus 30 is abnormal. Beyond 90 degrees is right axis deviation. Beyond minus 30 is left axis deviation. So like we said here, if the overall direction, this is normal, let me draw the normal. Normal is between this. If you find the overall axis here, this is left axis deviation because it moved from here to here on the left side. If the vector is here, it means it moved from here to here. This is right axis deviation, okay? Right axis deviation, left axis deviation. We'll talk about the pathologies with which these happen later, but you need to know that this is what deviation means, okay? Now, how do we determine from an ECG the axis deviation? There are rules. You have to remember this. This can come in MCQs or even OSPI. Well, they'll ask you what's if there is deviation or not, and they'll give you an ECG. So the formula for this, you have to look at two leads, lead 1 and AVF, okay? If lead 1 is normal, which means it's positive, and AVF is positive, it means it's normal. There's no deviation, okay? If in lead 1, the deflection is upward, and in AVF, deflection is upward, which means positive deflection, this is normal. If in lead 1, it's positive, so positive deflection in lead 1, but in AVF, it's a downward deflection or negative deflection, this is a left axis deviation, okay? If in lead 1, it's a negative deflection, and in AVF, it's a positive deflection, then it's a right axis deviation. Now, if you're like me and you hate to memorize, how do you remember this in the exam? You just draw the axis. So this is 90, okay? This is the y-axis, and this is the x-axis, صح? This side of the x-axis is positive. This side of the x-axis is negative. This side of the y-axis is negative. This side of the x-axis is positive. You know this from high school. Now, our normal is between 90 and, let's say here is minus 30. Okay? If it moves, okay, first lead AVF. Lead AVF is this one. Okay, so it's as if this y-axis is, I need a new page. Okay, you can just use this one. So pretend this is an x-axis and a y-axis. So you have lead AVF. Okay, it's in this direction. And you have lead 1 is in this direction. Okay, so this is the negative side of AVF, and this is the positive side. This is the positive side of lead 1, and this is the negative side of lead 1. Okay, so just draw this. Now, if you have an axis that's here, okay, this means that it's in the negative of lead 1 and it's in the positive of AVF. So this is right axis deviation, it's in the right side. Okay, let's say you have an axis that's here. This is left, and you know this is left because this is right and this is left. So this means that it has the negative from the AVF and it has the positive from the lead 1. Do you get this, or do I repeat? I think I'm gonna repeat this.
From what I understood, I don't know about the rest.
Does everyone get it? Is there anything in the chat?
No.
Okay, I'll just summarize quickly one last time because I feel like it was kind of messy. Just to go through it. Okay, let me use this space. Just draw this line. This line is your AVF. Okay. Let's use a different color. This line is your lead 1. Okay. This side of lead 1 in general is positive. This side of lead 1 is the negative. And then this side is the positive. And wait. This is the negative. How do you erase? Okay. And this side is the positive, okay? So right axis deviation means it's somewhere here. So the lead 1 will be negative and the AVF will be positive. Is that right? Yes, lead 1 negative, AVF positive. Okay, just making sure. Okay. Now, let's say you have a left axis deviation, so it's going to be here. This means lead 1 will be positive, AVF will be negative. Okay, so in the exam, just draw these two arrows. This is lead 1, this is AVF, positive side, negative side, positive side, negative side. So it's like the opposite of how the y-axis is in math in general, okay? So positive, positive, negative, negative, okay? Positive, positive, negative, negative. And then if they ask you, if you want to remember the left axis and right axis, draw one that's a left axis deviation and draw one that's a right axis deviation. You'll immediately remember, okay, so right axis, one, okay, negative, and then you just look at the ECG. We'll practice this in examples. This, inshallah, this is clear. You have to remember this, okay? I don't like memorizing, so that's why I keep drawing this every time I need to remember it. Oh, it's drawn for us here. Okay, so I forgot I put this table. So this is a normal axis. If it is a left axis deviation, which is here, it means that the lead 1 it's positive and the AVF is negative. Okay, because this is positive, this is negative. Okay, and if it's a right axis deviation, that means that the lead 1 is negative because it's in this side, and the AVF is positive because it's in this side. I'm just repeating this so many times because it's really important. What if it's here? It's really, really to the right, which means that both are negative, okay? This is the negative side, this is the negative side. Both are negative. This is extreme axis deviation. Okay, so this is basically more on how to understand it. Okay, again, the exam, just draw coordinate plane, positive, positive, negative, negative, and then just draw the arrows and you figure it out. Do you have a question on the axis deviation? I'm sorry if this was confusing.
No, that was understood.
Okay, I'm glad. So there are many causes to left axis deviation. I'm not going to go too much into it, but if you think about it, common sense, if they have left ventricular hypertrophy, it means that there's a lot of electricity going on in the left ventricle because now the muscle is huge. So the direction of the conduction is going to go towards the left. You'll have a left deviation.
Layan, we cannot hear you.
Dan, we can't hear you. I think you should fix the Wi-Fi.
Are you recording? Okay, so what's the
Normal.
axis deviation? Normal. Okay, why is it normal?
Because lead 1 and AVF are positive.
Exactly. So the two leads we look at are lead 1 and AVF. In the exam, we know that this is positive because the QRS complexes are pointing up. So if you draw the coordinate plane, this is AVF, this is lead 1, plus, plus, minus, minus. They're both positive, which means it's here. So this is normal, okay? Okay, what about this one?
Left axis.
Why?
Because one is positive and AVF is negative.
Exactly. So if you look at lead 1, the QRS is up, so that's positive. In AVF, the QRS is dipping down. This means it's negative. Okay? So again, if you draw it, plus, plus, minus, minus, lead 1 is positive and AVF is negative, so it's here. Okay, so this is left deviation. Do you guys know how to apply what I'm drawing, or is it confusing you?
It's clear.
Okay. Okay, is this the same one? Or... yeah. Okay, what about this one?
This is normal.
Normal, okay, exactly, because it's positive in one and wait.
It's positive in one, negative in AVF, but then we confirm with lead 2. And lead 2 is
Exactly. Yes. So the thing with left axis deviation is that you can only confirm it by looking at lead 2. If lead 2
Can you
is
repeat again because you were lagging?
okay, sure. I'm getting the router now, so inshallah it will be fixed. But which one, ECG 2 or 3?
Three.
Okay, so there is a rule where for left axis deviation, just 1 second. Let's draw this. AVF lead 1 plus minus. In this one, in lead 1, it's positive, and in AVF, it's negative. So you would think it's left axis, right?
Yes.
Yes. Why is it normal? Because with left axis deviation, thank you for reminding me, for left axis deviation, there's a third step to make sure it's left axis deviation, which is we look at lead 2. Lead 2 is always negative in left axis deviation. So if you look here, lead 2 is positive. This means it's actually normal. Okay, it's just some minor like things, you know, it's not really a pathology of the axis. Okay, so I think I put it here somewhere. I'm not sure. But is it clear that you always double check left axis deviation by looking at lead 2?
Okay. No.
Okay, tamam. What about this one?
Right axis.
Yes, why?
1 is negative and AVF is positive.
Exactly. So yeah, I'm gonna keep drawing this until it gets easy. Lead 1 plus minus. So here in lead 1, it's in AVF. Wait, no, I mean, sorry. In lead 1, it's negative, and in AVF, it's positive. Lead 1 negative, AVF positive means it's here. So this is right axis deviation. Is this clear?
Yes.
Okay, am I still lagging?
No, you're okay now.
Okay. Okay, so back to this, we know how to determine the axis, we know how to calculate rate, determine regularity. You just look at the P waves if they're here or not. What's the normal PR interval? How many squares?
3 to 5.
3 to
Yes,
5.
3 to 5 squares. What about QRS?
1.5 to 2.
Squares or
Square.
the QRS complex, yes, 1.5, 2.5. Perfect, okay. So, do you have a problem with any of these steps before we continue? We talked about rates. We said if it's regular, we use 300 divided by big squares. If it's irregular, then it's the number of QRS complexes times 6. Okay? And which strip do we look at? Look at the strip at the bottom of the ECG to calculate the rate. Regularity, you just see if it's the same space between each QRS. For the P waves, you just check if they're present or not. PR interval should be 3 to 5 squares. QRS should be 1.5, 2.5. And the axis, we talked about the coordinate plane. So any problems with any of these steps?
No.
Okay, cool. Now let's do this practice question. What do you think the answer is?
D.
Okay, do you guys agree or does someone have another answer?
D.
D, okay. So the PR interval, like we said, it's the part where, over here, this is the PR interval, okay? So it's where the atrias are contracting and then we have the delay from the SA node to the AV node. Now, when you are exercising or there's sympathetic stimulation or exercising or exertion or fight or flight, this will become shorter because your heartbeats will be really way faster. So it is affected by innervation. Okay, so it's not this one and it's not this one. And distance between beginning of P wave, which is here, to middle of QRS complex, no, it's from the beginning of the P wave to the beginning of the QRS. So it's D. Okay, 120 to 200 ms means 3 to 5 squares. Now, what about this one?
D.
D?
Yes.
Yes, it's D. Do you guys remember this one? Please remember this one.
Yes.
Okay. Tamam. What about this one?
Extreme.
Okay, why? Because both leads are negative, so?
Yes. Both of them are like.
Yes. So I'll just draw it one more time just in case. Plus, minus. Lead one is negative, so we're here. Oops. So we're in this side. Lead one is negative. AVF is negative command, so we're on this side. So extreme axis deviation. Okay, what if I told you that lead one was positive and AVF is positive? Normal. Okay, what if lead one was positive and AVF was negative?
Left axis, but we have to check lead 2.
Okay, perfect. Lead 2 is always negative with left axis deviation. Just keep that a rule. Now, do you guys have any question regarding the axis?
No.
Okay, so let's start with arrhythmias. Now, we have two types of arrhythmias, either tachyarrhythmias or bradyarrhythmias. Tachyarrhythmias means that the heart rate is above 100 because the normal heart rate is 60 to 100. So above 100 is tachyarrhythmia, below 60 is bradyarrhythmia. So we'll start with tachyarrhythmias. Now, this diagram is what saved me through studying tachyarrhythmias. It has everything you need to know, everything that makes you read ECGs like a breeze. So helpful. And this one is not in your lectures, صح?
The table?
Yeah.
No, it wasn't in the lecture.
Yeah, so this table is from Rafi. He gave us a session last year, and it's an amazing table, so thanks to him. So how do you interpret tachyarrhythmias? This is how you approach tachyarrhythmias, okay? First thing, what is a tachyarrhythmia? It means that the space between each QRS complex is less than 3 squares. Makes sense because 3 squares means that the heart rate is 100. So if you have less than 3 squares between each QRS complex, your heart rate will be over 100. So it's just another way of telling you that tachyarrhythmia is greater than 100 beats per minute. Now, first thing you look at is the QRS complex. Is it narrow or is it wide? Let's start with narrow. We'll focus on this for now. After that you see that the QRS complex is narrow, you look, is it regular or irregular? Okay, let's focus on the regular. Let's say you looked at the tachyarrhythmia, it's narrow QRS and it's regular. What's the next thing? You look at the P waves. Is there a P wave or is there no P wave? If there is a P wave, you have two options. Either it's a normal P wave with a normal axis, that's sinus tachycardia, or it's an inverted P wave or abnormal P wave, that's atrial tachycardia. Okay, if there's no P wave, then it can either be an atrial flutter or supraventricular tachycardia. So I'll be focusing on these for now. So in general, tachycardia means greater than, this will go through this, don't worry. So this is basically how he classified it in the lecture. I think that the table is way more helpful. Who can try to do this one with me.
I could.
Okay, yes, okay, go ahead. What's the first thing we look at?
So we look at the rate first.
Okay, does it,
And there's two
yeah,
boxes.
okay, so this is tachycardia.
Yes. The
Okay.
rhythm seems regular.
Okay, if this is a tachycardia, what's the first thing you look at?
The QRS.
Yes, exactly. Sorry. So is it narrow or wide?
Narrow.
Very narrow. Looks narrow, صح? Very narrow. Now, now you check. Is it regular or irregular?
It's regular.
It's regular. Is there a P wave or no P wave?
There is a P wave.
Yes. Is the axis normal or abnormal?
Normal axis.
So what is this?
Sinus tachy.
Exactly, sinus tachycardia. So if you want to take, do you guys have the slides or no?
Your slides?
If you want to take a screen, yes.
They'll be sent later.
Oh, okay, so if you guys want to take a screenshot of this, so you can follow along with the ECGs. So what we did now, we checked its tachycardia because there were only two squares. The QRS was narrow and it was regular and there was a P wave and it was normal. So you can diagnose with sinus tachycardia. Okay, so just take a picture so that you can easily follow along. Now, what is sinus tachycardia? Sinus tachycardia is a normal working out. Everything is normal, it's just your heart rate.
You are lagging.
Sinus, the word. Sorry, 1 second. One second. Okay, so sinus, the word sinus means that the rhythm of the heart, it's like it started or it's sent from the SA node or sinoatrial node. So when we say something sinus, like sinus tachycardia or sinus rhythm or anything sinus, it means that the conduction is normal. It's being generated from the SA node. It's a normal rhythm. SA node is generating the impulse, so it's normal. It's just faster than normal. Okay, so it's not pathological. This is normal. It happens during exercise, stress, or illness, or exertion. It's not pathological. Okay, and the way we can tell that this is sinus, without following the table that we made, if you just want to think about it, you check if there is a P wave, okay, first thing, and you check if the rhythm is normal. If you have a P wave that's normal and a rhythm that's normal, or like it's a regular rhythm, then you're most likely dealing with something that's sinus, okay? So any questions on sinus tachycardia?
No.
Okay, now try this one. Have the table next to you. Did you take, like, if you have the table next to you, will help you solve this. Who wants to try to solve this? Okay, we can do it together. So first thing is you look at the rate. Okay, دايما أول شيء you look here on the strip that's down. We look at the rate. Between each QRS complex, you have like 1.5 boxes. That is definitely tachycardia. Once you find that this is tachycardia, you follow the tachyarrhythmia table that I showed you. So first thing is you check QRS complex. Is it narrow or wide? It's very narrow, okay, which is like the normal QRS complex, it's narrow. Second step, is it regular or irregular? It looks very regular, صح? 1/2, 1/2, 1/2. It's regular. Third step, is there a P wave or no P wave? Do you guys see P waves?
Yes.
Yes, there are P waves, but they're inverted, صح? They're abnormal.
Yeah.
So what do we call this?
Atrial.
Yes, atrial tachycardia. Am I lagging still?
No.
Okay, so this is atrial tachycardia. Okay, is it clear how to approach this part? We did this one and this one.
Yeah.
Okay, now what about this one? This is very high yield. You'll get this in the exam 100% or 90%. Very important. This is one of the ECGs that's just pattern recognition. Like you just look at it and you know.
Flutter, atrial flutter.
Yes, exactly. This is the sawtooth pattern. Okay, this is atrial flutter. So if you want to follow the table when solving this, you can. But it's difficult because me, when I studied this the first time and I applied the table, I got lost because I was like, this isn't tachycardia. Like it's like 5 squares. You know, how is this tachycardia? But atrial flutter is considered tachycardia because the way atrial flutter is the atria themselves are fluttering. They're not even contracting fully. It's just like half a contraction. What about, you know? It's barely contracting. And every like 4 to 5 flutters, you get a ventricular contraction. You know, a full ventricular contraction. That's why you get like atria, then ventricle, you know? So it is tachycardia because each of these is technically kind of like gives you a heartbeat, you know what I mean? So this is tachycardia. Atrial flutter is very high yield. I saw this in many past exams. So what you need to know from all of this talking is atrial flutter is caused by macro reentrant or a macro reentry circuit. What that means is normally in the atrium over here, you have the current going from the sinus node and then it gets conducted and it goes to the AV node and blah, blah, so on. What happens here is the impulse, instead of going down, it kind of circles back around and it like irritates or reinstigates the SC node again, then it sends another impulse, then it goes back in a circle. So it's a re-entry. Instead of the impulse traveling down, the impulse kind of like moves in a circle inside the atria and keeps instigating and reinstigating, you know? So the atria itself is kind of like fluttering. It's not a full heartbeat. It's not a full contraction. That's why with it, you don't see with every flutter a QRS. It's flutter, then QRS, because these aren't full atrial contractions, you know? They don't all cause a ventricular contraction. Not every impulse that circles inside reaches the ventricle. So every 3 to 4 flutters, you have a QRS, because not every impulse reaches the ventricles, because it's an abnormal impulse. So the ventricular rate over here, if you see, the ventricular rate is kind of like a 2 to 1. For every 2 atrial flutters or impulses, you get 1 ventricular contraction. That's kind of how it looks like. Is the atrial flutter clear?
Yes.
Okay. So please know this image by heart, sawtooth appearance, okay? Now, what about this one? Follow the table.
SVT.
Okay, why? Do you want to solve it with me?
Because there is no P wave.
Exactly. Now, if we go from start to finish, this is tachycardia, صح? Because the heart rate, it's less than 3 squares. So we know
Yes.
that it's tachycardia. What's the second step? We look at QRS, صح? Is it narrow or wide?
The QRS.
Yeah, is it narrow or wide? I think you're lagging, but yes, it's narrow.
Yes.
Then, yes, is it regular or
Yeah.
irregular?
Regular.
Okay, is there a P wave or no P wave?
No P wave.
Exactly, so it's SVT. If you look at
SVT.
the table, yes, narrow QRS, regular, no P wave, and it's definitely not an atrial flutter. There's no sawtooth, so it's SVT. Okay, so this is supraventricular tachycardia. Now, how does this happen? Why do arrhythmias happen in general? What you need to know from this is that in general, arrhythmias happen because there's either enhanced automaticity or abnormal automaticity, which means that the automatic SA node either depolarizes faster than normal or it's depolarizing abnormally. These are two ways this can happen. But the most important thing for you to remember is that the most common form of supraventricular tachycardia is caused by AVNRT. What's AVNRT? It's AV nodal re-entry tachycardia. Okay. Now, normally, sorry.
Read this again.
Are you lagging or am I lagging?
They're lagging.
Oh, okay. So, do you want to type what you're saying in the chat? Because I can't hear you. Whoever is talking. Okay, if there's anything in the chat, let me know, okay? So AVNRT is AV nodal re-entry tachycardia. How does this happen? Usually, the impulse travels from here. You have an SA node. It's going to travel to the AV node. There's some delay. Then it continues to the bundle of His, left and right bundle, branches, Purkinje, everything. This is the normal way things flow. Some people, they're born with like a slow, this picture. Some people have this conduction pathway. So what happens is, instead of everything flowing in one direction, they have two conduction pathways. So here are the atria, okay? They have two conduction pathways. This is basically the AV node, and then these are the ventricles. Okay, so usually things just go in one straight line. Some people are born with like the two pathways where the impulse travels in a slow manner on one side and the fast manner on the side. Okay, so if you can see here, you have an impulse that comes from the SA node after it leaves the atria. It moves in a slow pathway and a fast pathway, but then they cancel out when they meet and it just goes down as one. Okay, so these people, they're living normally. Okay, it's not any, it only manifests in the second and fourth decades. Okay, they're living normally because usually you have a slow impulse and the fast one, they cancel out بتصير واحدة, and it goes to the ventricles, normal ventricular contraction. So they don't really present with anything. But why does it manifest, or how does it manifest when you have a premature beat? Sometimes the SA node the SA node, it's going to send out an impulse too early. It's automatic. Usually it sends out impulses at 60 beats per minute. Okay? And then when it's sent out, it travels slow, fast, cancels out, goes back down. Now, it's normal. What triggers this is sometimes one goes down, okay, everything is supposed to be normal, but then the SA node gives another impulse a bit too early, okay? So what happens is this impulse that comes too early, it doesn't find anywhere to go, it re-enters, kind of circles back, and it instigates the SA node, which fires again, and then it becomes like a circuit. It re-enters, okay? So this is why it manifests in these people. So as you can see here, it's often well tolerated, okay? But it can manifest when it's triggered. This is the word I've been looking for since the beginning of the session. Triggered, yes. So they live normally, everything is okay, but it can get triggered from like premature beats or any abnormal impulse here and there. It can be sent down, and because there are two pathways, it can circle back up and re-trigger the SA node, which will send more and more and more and more. So it's gonna kind of like it's a re-entry circuit, okay? This is the most common form of SVT. This is what causes what we see here, okay? So you'll have like a really fast heartbeat. This is basically one mechanism. It's the most common one, just know that. Another mechanism is early depolarization or early repolarization. Now, if you remember this from first year or from physiology, you have an action potential. It needs to fully like go back to normal or rest for the second one to be triggered, okay? In some cases, a second impulse is sent before you relax, so a second action potential. Before it even fully relaxes, a second action potential. Before it fully relaxes, a second action potential. So this happens, okay? So this is also one mechanism why arrhythmias happen, okay? It's called triggered activity. Not too high yield, but just remember that what early after depolarization and just know that they look like this if you get the picture, you know? So delayed after depolarization and early repolarization, okay? So what's this one? This one is also very high yield. I've seen this in many pasts. This is atrial fibrillation. So atrial fibrillation, you don't see P waves. Do you see any P waves?
No.
No, there are no P waves. There are like bumps. You know, this is not P wave. Be careful. Okay, we look at the one that's before the QRS. So here. Okay, there are no P waves. There are more like bumps. So when you see no P waves and irregularly irregular, see it's very irregular. They're very irregular. Immediately think of AFib, atrial fibrillation. The key word to remembering AFib, sorry, this one is also, or you tell me, what's this one as well? Do you see any P waves?
No.
No.
No, exactly. There are no P waves, you just see squiggles, you know? So this is also AFib or atrial fibrillation. The key words to atrial fibrillation or recognizing atrial fibrillation, one is no P waves, two, irregularly irregular. Okay, so see how there's a huge difference between each QRS complex and it doesn't follow a pattern. So it's irregularly irregular with no P waves, AFib immediately, okay? So atrial fibrillation, it's similar to atrial flutter, but it's not the same. Atrial flutter is caused by a macro re-entry. So it's one big re-entry circuit. In atrial fibrillation, you have many re-entry circuits happening all over the atria. Like, is there a picture? Let me see. No, but let's say you have the heart, okay? You have a re-entry circuit here, a re-entry circuit here, a re-entry circuit here, re-entry. So it's being activated in like micro impulses all over the atria. It's very irregular activation. That's why you do not get a P wave. There is no full atrial contraction. It's just like mini vibrations here and there. Barely anything, okay? See, there's barely anything. There's just mini vibrations because you have many re-entry, micro re-entry circuits, really small ones here and there. In atrial flutter, it's one big re-entry circuit. It's a macro re-entry circuit. So you stimulate the You stimulate the atria, then you stimulate it again, then you stimulate it again, and you stimulate it again. So it almost looks like many big pumps for the sawtooth appearance. In atrial fibrillation, it's micro re-entry circuits all over the atria. You have micro, so like you have the heart, there are like small areas all over the heart that are being triggered with micro re-entry circuits. So it starts like kind of vibrating. Okay, that's why you get these tiny, tiny little squiggly lines. This is very important to know when you see it, okay? So sawtooth appearance, atrial flutter, no P waves and irregularly irregular, looks like mini vibrations, atrial fibrillation, okay? So this is basically what we said. Now, atrial fibrillation, it's really important because it's life-threatening. Now, the reason it's life-threatening, it's because if you think about it, it's many vibrations of the atria, okay? There's no contraction for the atria. So you're not really sending blood out to the ventricles. It's just staying there in the atria being vibrated. So if there's no blood going to the ventricles are not contracting the blood to the body. It's really, really life-threatening, okay? Now, causes, you can read them. Not too important. They're important in like pathology and stuff like that. Let's focus on the ECGs. Main thing I want you to remember, I'm not going to mention management for anything except for AFib or VFib because they're important. For atrial fibrillation, the thing you have to keep in mind or remember is that it can lead to strokes. Why? Because the blood is sitting here in the atria and the atria are just vibrating, okay? So the blood is not flowing, and anything that interrupts blood flow can lead to clot formation. So the blood is just sitting there, it will start clotting. So when there is like a beat or an atrial contraction, the blood is gonna go to the ventricles with the clots. Okay, sorry, that's my parrot. But yeah, so you have blood clots going to the ventricle. Ventricle is pumping to the rest of the body. You'll have blood clots in your blood vessels in general, and it might get stuck and it might lead to a stroke. Okay, so when you manage atrial fibrillation, there are two aspects of management. You need to manage the stroke prevention and you need to manage the arrhythmia. For strokes, you just give anticoagulants. To see here, there's like a clot that formed because the blood is not moving, it's just vibrating in its place, it's not flowing. So you give anticoagulation to prevent the strokes. And part B of the management is that you manage the rate by giving beta blockers, calcium channel blockers, digoxin to calm down the heart because it's pumping too fast. Or you can mix antiarrhythmic medication, or you can do DC cardioversion. DC cardioversion, it's not the same as defibrillation, like the one you see in movies where they say clear and they shock the heart. That's defibrillation. Cardioversion is when you give small shocks in a very ordered manner every Q wave, or like you have the ECG, صح? So cardioversion is basically you shock the patient or you give a small shock to the patient every time you reach here, like the QRS. You don't need to know the details, but you just keep giving shocks, okay? But in a very regular, organized way in hopes of regenerating the rhythmic system of the heart, inshallah, and like makes it go back to the normal rhythm, okay? So again, how do you manage atrial fibrillation? Two parts, arrhythmia control and stroke prevention. Stroke prevention, you give anticoagulants. Arrhythmia control, you can either give rate control, any things that slow down the heart, or you give rhythm control, which is antiarrhythmics, or cardioversion, which is where you give small shocks to the heart in an ordered, specific manner to restore the normal rhythm of the heart. Okay. Any questions on atrial fibrillation? Because it's very important. Did I lose you guys?
No,
Okay,
no,
I
no,
hope it's
thank you.
okay, cool. What about this one?
Multifocal.
Okay, why?
Because there are three P waves which are different from each other.
Exactly, perfect. So this is multifocal atrial tachycardia. Now, how do you recognize this? First is there is usually a hint in the question. It's always COPD related or lung disease related. And second thing is that there are three or more different P wave morphologies. So let's look, for example, here at the lead 2 strip. Do you see how the P wave looks different every time? It's different, but it is a P wave, but it just looks different each time. Okay, so this is multifocal atrial tachycardia. Now, the causes to multifocal atrial tachycardia are usually a pulmonary disorder or like chronic obstructive lung disease, pulmonary disorders, or drug use. Okay, how do you treat multifocal atrial tachycardia? You just treat the lung disorder and it will go away on its own. Okay, now the reason this happens is because you have, I don't want to go into details, but you have like ectopic tissue, and each one of them is giving the atria a contraction. Okay, so each time the atria is contracting because of a different impulse it's receiving. That's why each P wave looks different, because not each one is because of an impulse from the sinus node. No, each time the atria is contracting because of an impulse from a different location. So each P wave looks very different. Okay, so all you need to know is how to recognize it, that it's three or more different P wave morphologies. You can know that it's multifocal atrial tachycardia and know that it's usually associated with pulmonary disease. Now, we talked about sinus, we talked about atrial, talked about flutter, we talked about SVT, we talked about atrial fibrillation, and we talked about the multifocal atrial tachycardia. So one thing I forgot to mention is that the reason we classify into narrow or wide is because narrow QRS means that the ventricles are normal, صح? Because it's normally narrow. So if the QRS is narrow, it means that the problem is coming from above the ventricles. That's why all these reasons over here are these pathologies, they're all atrial. Atrial flutter, atrial fibrillation, atrial tachycardia, atrial multifocal atrial, it's all atrial. Because narrow QRS means QRS is normal, it's narrow, ventricles are normal, problem is coming from above the ventricles, okay? So whether it's a problem in the sinus node, a problem in circuits that are happening in the atria, whatever it is, it's just above the ventricles. Wide QRS, you'll see it now, it looks very, very obvious that because the QRS is wide, it means that there's a problem in the ventricles. So all of these are the pathologies are arising from the ventricles themselves, whether it's re-entry circuits in the ventricle or the fibers aren't conducting well in the ventricles. It's in the ventricles. So is this part of the table clear so far?
Yes.
Okay, cool. Sorry again, that's my parrot. Okay, so what about this one?
Ventricular tachycardia.
Exactly. Now, if you see here without even having to count or follow the table or do anything, the QRS complexes are very, very, very wide. Okay, so immediately we go to this side of the table. Okay, without even having to check, okay, heart rate rhythm, blah, blah, just wide QRS complex, and it's regular. You see how it's regular, like it's following a pattern, very, very regular. Immediately we go with ventricular tachycardia. Okay, so this is a really important picture because it's also one of those ECGs where it's recognition. You just look at it and you know. So it's wide QRS complexes that are very regular. Immediately ventricular tachycardia. Okay. What about this one?
Ventricular fib.
VFib?
Yes, ventricular fibrillation.
Why?
Because you cannot see the QRS here. I mean, it's moving.
Okay, I understand why this can confuse. I completely agree. but there's a specific pattern here. Yes?
Yes.
What's the pattern?
Here, yeah.
What does this look like?
Fibrillation.
Okay, another guess. Okay, this is torsade de pointe. Do you guys know this?
Yeah. صح.
Okay, so I understand why this can be confusing. Completely agree. It kind of looks like VFib, especially if you look at the one that's the bottom strip here. But inshallah, when I show you the VFib, you'll see the difference. Hello. This is a very specific pattern. It looks like a sinusoid, you know, like it's thin then thick and thin and thick. Kind of looks like this. Okay, when you see this kind of pattern, it's torsade de pointe. It's diagnostic, this feature. Okay, so, or like, as the table calls it, it looks like the cover for Arctic monkeys, if you guys know that. This is torsade de pointe, very important as well. So this is the normal ventricular tachycardia that we were talking about. White QRS, regular. Okay, this is ventricular tachycardia. When it's polymorphic in this manner, okay, this is what we call the torsade de pointe. Okay, it's a polymorphic ventricular tachycardia. Okay, now this really similar, like ventricular tachycardia or polymorphic ventricular tachycardia, is similar to the multifocal atrial tachycardia. It's just that they're in the ventricles, not the atria. Okay, now torsade de pointe is basically, what you need to remember is it looks like a twist. It's as if you have like a rope and you're twisting it. Okay, so that's what I want you to know. So do you see this pattern? This is torsade de pointe. It does look like VFib, I agree, but when I show you the VFib picture, you'll see a clear difference. It looks very different. Okay, now why does this happen? The reason this happens is usually because of triggered activity. Okay, so what happens is, remember when we said usually an action potential, it has to go back to resting and then get triggered again. What happens in torsade de pointe is that something triggers the action potential before it's fully rested. So it's instead of fully resting, it gets triggered here, then it gets triggered here, then it gets triggered here. It doesn't go back down. Okay, so this happens because of either as a side effect of antiarrhythmic drugs. Of these two, I think you guys need to know them. From what I remember, erythromycin and quinolones, they can predispose to torsade. You need to know in your antiarrhythmic lecture for the drugs, there are certain drugs that can lead to this as well. So you need to remember those as well. This mainly, all of these drugs or antibiotics or triggers, what they lead to is a prolonged QT. Now, if you guys remember, you have the P wave, QRS, and then T. The QT interval, it's basically the contraction of the ventricles and the relaxation of the ventricles. What happens if you prolong this period of time? Okay, it means that the ventricles are taking longer than normal to go back to resting. Okay, which means that there's a higher chance for it to be triggered before it's fully rested, which leads to this happening, like triggered activity before it rests or repolarizes completely. So you don't really need to know the mechanism in that detail, but just know torsade de pointe is because of triggered activity, usually by drugs, antibiotics, and mainly they lead to prolonged QT, which leads to the torsade de pointe that we see. So yeah, this is basically what I was saying. This triggered activity, what you're seeing here, this is one of the mechanisms for the TDP or torsade. So we did this and we did this. Any questions on these?
No, thank you.
Okay. Oh, this one is labeled already. Okay. So this one is Wolff-Parkinson's-White. Now, how do you recognize this on ECG? There's like this kind of mnemonic that W it doesn't actually stand for wave. Like these stand for scientist names of the scientists that discovered them. But yeah, they're named Dr. Wolf, Dr. Parkinson, Dr. White. But a way to remember it is wave for wave delta. You'll see a delta wave, and I'll tell you what that is in a bit. You'll see a short PR segment and a wide QRS. When you see these three together, it's immediately Wolf, Parkinson, White. So let's see. Let me just show you. Yes, here. What's the delta wave? Delta wave is basically this notch that you see here. Instead of normally, the normal ECG is the black dotted line. Do you see the black dotted line here? It's supposed, the QRS complex, it's supposed to dip down a bit and then go back up. The delta wave is, it actually kind of notches up. It doesn't dip down and go back up, okay? That's the delta wave, first thing. Second thing, the PR would be really short, okay? It would be like less than a square maybe over here. The PR interval is really, really short. See, it's like this area over here. Third thing is you have a wide QRS complex, okay? So let's apply this information here. Look at lead 1. Do you see the delta wave? It like looks like this, and then instead of the Q wave which goes down, you have a like kind of a delta wave. This is the first thing. The PR is so small. Let me show you. The PR interval, which is this right here, there is barely any aslan there. It's barely 1 square. Okay, so short PR, delta wave, and wide QRS. All of these, Wolff Parkinson syndrome. Okay, now this is actually a congenital, what's it called? Congenital pathology, like you're born with it. And these people, they're born with an accessory pathway in the heart. So what they're born with is called the accessory pathway over here. It's called the bundle of Kent, okay, or Kent fibers. Normally, people don't have that, but these people, they're born with this accessory pathway, and it leads to the conduction going from the atria directly to the ventricles without passing through the AV node, okay? That's why you'll see this kind of like bulge here, because the PR is really short because there's no AV node delay, because this accessory pathway surpasses the AV node. The conductions or the impulse, it goes from the atria straight to the ventricles. It kind of bypasses the AV node. That's why the PR segment is now very short. Okay, so this is the accessory pathway. And why is the QRS complex wide? Because now the ventricles are contracting because of a different impulse. It's not the normal sinus node and then AV node and then Purkinje, bundle of His, left bundle branch, right bundle branch, Purkinje. It's not the normal system. It's going through a different accessory. The contraction of the ventricles won't look completely normal. It can't, you know, it will only look completely normal if it's following the normal conduction system. So that's why we see these signs. Is this clear? Inshallah, I hope.
Yes.
Okay. So, okay, what about this one? Do you see any proper QRS?
No.
No. Do you see any pattern, any?
No, no.
No. So what is this?
VF.
Yes, exactly. This is ventricular fibrillation. Do you see the difference?
Yeah.
Yeah, let me just show you again. This is, see the difference? There's no pattern or anything. This one has kind of a pattern, which is the sinus like this. And this one, yeah, this one doesn't have any pattern. Okay, so our tachyarrhythmias clear because they're very important to recognize. We talked about all of these. Okay, so just a quick summary before we move on. Okay, quick summary, because we're done with tachyarrhythmias, is first thing you look at if it is a tachyarrhythmia in the first place, which means more than 100 beats per second or less than 3 squares. Second step, is it narrow QRS or wide QRS? If it's narrow, you look at if it's regular or irregular. If it's regular, you check if there is a P wave, if there's no P wave. And then if there is a P wave and it's normal, it's sinus tachycardia. If there is a P wave but it's inverted, it's atrial tachycardia. If there's no P wave and it looks like a sawtooth, flutter. If there's no P wave and it's just QRS complexes with no P waves, then it's supraventricular tachycardia. If it's irregular, it can either be atrial fibrillation or multifocal atrial tachycardia. Atrial fibrillation just looks like vibrations, mini vibrations, barely any atrial contraction, very life-threatening. Biggest complication to atrial fibrillation or like result of atrial fibrillation is strokes because of the blood clots that can happen. So remember, when we treat AFib, we need to give anticoagulants and antiarrhythmics or rate control. For multifocal atrial tachycardia, you have more than 3 or 3 or more P wave morphologies. Okay, now VFib just looks like complete mess. There's no QRS, no P, no nothing. It's just squiggly lines everywhere with no pattern. For wide QRS, if it's wide and regular, it's a ventricular tachycardia. If it's wide but it's irregular and it looks like a sinusoid or it looks like you're twisting like a rope, then it's TDP, okay, or torsade point. If it has the features of a delta wave, a short PR, and a wide QRS, then it's Wolff-Parkinson-White. Now, do you have any questions before we move on?
No, thank you.
Okay, so like I said, for management, the most two important ones are atrial fibrillation and ventricular fibrillation. For ventricular fibrillation, the way we manage it is we do defibrillation. In atrial fibrillation, we do cardioversion. The difference between them, defib is the one you see in the movies in the hospital where they clear and they shock the patient and everything. So the reason we do that is that ventricular fibrillation is life-threatening to like extremely life-threatening, way more than any other condition where the heart electricity. The reason is if your ventricles are not contracting properly, they're just vibrating all over the place. It means you're not able to contract this blood or pump this blood to the rest of the body. Okay, so the patient is usually unconscious. Okay, they're not even conscious at this point when they're in VFib. So what you need to do is immediately shock the patient without looking for, oh, in an orderly manner, not an orderly manner. It has to be every QRS segment we shock. No, or a QRS complex. Defib is just a shock. It's sudden. We don't care when it's timed, how it's timed. We need to shock to save patient's life. Okay, so remember defibrillation. For long-term management, we implant an electric defibrillator. Okay, because someone with VFib, there's a high risk of them developing it again. So we do an implant. Okay, so this is basically what they're telling you. Now, this is extra, but just in case you guys like want to know difference between cardioversion and defibrillation. Cardioversion, we use it for atrial fibrillation, atrial flutter, stuff like that. Defib, we use it for VFib, okay, ventricular fibrillation. Now, the way we do cardioversion is that we synchronize the shocks or the electric shocks that we give with each R wave. So we give a shock at each R wave, okay, so that it becomes like an orderly and we restore the rhythm. For defib, it's unsynchronized. We just give the shock immediately because we need to save the patient's life, okay? So there are different types of managements, basically. Cardioversion is non-emergent. Like someone with atrial fibrillation will be conscious, they will be awake, you know, but it's still life-threatening, again. But defib is like, it's life or death, okay, the ventricular fibrillation. So this is a summary of everything we talked about. So we're done with tachycardias. Let's just do some practice questions. What's this one? This will come in your exam. Do you guys want to give it a try or no? Are there any P waves?
No.
No, so what is this?
Atrial fibrillation.
Yes, exactly. So narrow QRS, no P wave, no regularity, AFib. What about this one?
Flutter, atrial flutter.
Atrial flutter.
Exactly, sawtooth appearance, atrial flutter. Okay, what about this one?
Ventricular
Attack.
tachyarrhythmia.
Exactly. So it's wide QRS and it's regular. Ventricular tachycardia. Okay. Practice question. Patient presents with COPD and a narrow QRS arrhythmia. What type of tachyarrhythmia is associated with COPD patients and what is the management for that arrhythmia? Do you guys remember which one is associated with lung problems?
Multifocal.
Yes, multifocal atrial tachycardia. So this one is usually caused because of the lung problems. So how do we manage this arrhythmia? We just treat the lung problem itself and it will go away. Now, just a reminder, multifocal atrial tachycardia is the one with more than 3 different P wave morphologies, okay? Now, what about this one? When managing atrial fibrillation, what are the 2 parts of treatment and what are they composed of? What's the most important complication that can arise from atrial fibrillation?
Stroke. So we give anticoagulant.
Exactly. That's the first part.
The second part, the rhythm. So we give
Exactly.
antiarrhythmic or rate control.
Exactly. Or cardioversion. Perfect. Okay.